Morning, everyone. Thanks for coming on this snowy day and making it up that hill. I'm surprised people made it up the hill. I think today's we're going to be focusing on some hypothermia and ischemia this morning, and so my first lecture will be on hypothermia and the trials and go over some of the experimental evidence that sort of backed them up, and what some of the follow-up has been over the last 3 or 4 years in that regard. But I thought I'd first start with a slide of my hometown, which is Edmonton, Alberta. This is taken yesterday. These are pictures I just quickly downloaded off the internet just to show you the similarities. Obviously the snow, we've got lots of it, and apparently we just got 10 centimeters as well. These are bison in one of our animal preserves just outside the city, and this is a skyline of the city of Edmonton, just taken yesterday as the sun's coming up with, you can see lots of snow on the snowbanks and transportation being a little bit clogged up. So we have very similar features across the latitude, only 5,000 miles away. So again, thank you for inviting me here, and we had a fabulous day yesterday and just a tremendous evening, and hopefully everybody's nice and relaxed this morning. Again, feel free to interrupt me if you have any questions or anything of that nature. Okay. So we're going to start with a bit of historical background with respect to hypothermia. I'll talk a bit about the research that went on that led to the use of hypothermia and standardization of that, an overview of some of the clinical trials that have happened, which are quite a number already around the world, some of the mechanisms that we believe hypothermia is the foundation of, and then where all of this might be going in the next 2, 3, and 10 years to improve on that standard of care. So just like yesterday, if you fall asleep, this is what I'd like you to take home. There's a few messages I think that are important about hypothermia. First of all, really in neonatology, we're kind of lucky in many ways because we've had a very rapid translation of hypothermia into clinical standards, certainly much more rapidly and much more successfully than any ischemic insults or frankly any clinical trials in the adult world. And I think that's been in large part due to the collaboration and cooperation of centers around the world, both in Europe and North America and across the ocean as well. So we've been, I think the newborn world has been very lucky in that way. And it's the only accepted and proven effective therapy that I'm aware of for hypoxic ischemic brain injury, and is obviously rapidly becoming a standard of care. We should recognize, though, that it's incompletely effective, and certainly we don't understand everything about it. And what I mean by that is it doesn't protect every child. It doesn't protect the severely injured child as much as we would like. And if we think about this, and we'll go into it a bit more, really it's a rescue therapy. In other words, the baby has an asphyxial event or a hypoxic ischemic event, and then we try and rescue brain tissue and systemic organs, as opposed to either prevent or create regeneration. And when we look at that rescue therapy, it's really within a very narrow time frame, really about within 6 hours. So it really applies only to those babies to a great extent that have an intrapartum asphyxial event. And if we remember from yesterday's lecture, that's probably only about 10 to 20% of the babies that we're now seeing in the nursery who have an ischemic event, the other 80 or so babies having an intra or an antepartum event or a combination of events that still require our attention. So future directions are going to move towards presumably some form of combination chemotherapy. And Donna Ferraro likes to quote the phrase cocktails and ice. So hypothermia and some other drug. And I'll speak to that a little bit at the end of this hour. And the other question is, what else can hypothermia be useful for? Is it going to have any value in babies who are premature? is it going to have any value in babies who have neonatal stroke, which is a different, slightly different entity than an intrapartum hypoxic ischemic event, and usually not identified till later on in the first 24 to 48 hours of life, and currently is not being used for either of those insults. So those are some of the take-home messages that you can write down, I think maybe in the syllabus or on the website right now. So hypothermia is really kind of an old idea, relatively old. It was born about 300 years ago by John Foyer, who suggested that babies might do a little bit better if they were cooled off right after birth. And then obviously there was a lag to go into clinical practice. And then in the 30s, 40s, and 50s, there was a recognition of successful resuscitation of near-drowning victims in cold water. And that's when that sort of began to raise eyebrows again. Deep hypothermia, like down to 15 degrees or 18 degrees centigrade, was starting to be used then for neurocritical care and for cardiac and neurosurgical care, and continues to be used for that, although the extent to which hypothermia or the depth of hypothermia is not quite as great at the present time. And then for the newborn in the 50s and 60s, and I'm sure there's more history than just this, a group of several neonatologists recognized that infants who are exposed to cold environments for prolonged periods of time, when they were just born sort of into the environment and the labor and delivery room or the case rooms were not heated, they were just born into the environmental temperatures, they noticed that there was an increased mortality and some cardiovascular compromise, and patients were getting coagulation defects. Now, recognize that in the 40s and 50s, obviously, we didn't have the kind of environmental controls that we do today. And so babies were really just put in their incubators and allowed or remained hypothermic for 5 and up to 7 days, at least based on what we know from those papers. And so it's not surprising that they had some side effects, but that's a little bit where thermoregulation sort of came into effect. In other words, they recognized that cooling the babies for that period of time turned out to be negative, and so thermoregulation came into play, and incubators became heated, and all the babies were maintained at normal thermic temperatures, and that stayed that way until the more recent past. And then there was a resurrection of hypothermia, really with animal studies done in adult stroke. So rodent studies done by groups in Miami and I think Philadelphia as well recognized that if you drop the temperature by 2 to 4 degrees in animal models of stroke was a good thing and was actually very neuroprotective. And they noticed that if you drop the temperature during the event, so if you induce a stroke in a rat, and during the time that the rat is having a stroke, you drop the temperature by 2 to 4 degrees, it's fabulous. In fact, it works wonders. The problem is you don't always know when you're going to have a stroke. So you can't walk into a freezer at the time that you're having a stroke. So then they started to look, well, what if you drop the temperature after the stroke when you actually know it's already happened? And that seemed to provide some transient benefit. And if you prolong the extent to which you kept the animals hypothermic, then that was very effective. And so that was happening in the adult stroke world, and then people started to look at it in the newborn. And when I was training with Bob Vanucci back in the early 90s, I suggested to him that we look at this, and he said, no, don't look at it. It's never going to work. Don't do it. So I did anyway, because you always don't listen to your mentor, at least a little bit. And we looked very early, and this is an intra-ischemic group of rats. So we looked at our 7-day-old rat model, in which we tie off the carotid artery, and it's a very common model used for perinatal asphyxia. And we put them into water bath and we cooled the temperature down to about 31 and in some circumstances 28 degrees. And we took the rat's temperature. And like most of you probably know, babies are not as thermoregulatory as adults are. And so they become so-called poikilothermic. In other words, they mimic their environmental temperature. And their temperatures went down to about 31 or 32 degrees. And then when you took them out of the hypoxia-ischemia, they resumed their relatively normal temperature. And we found that when we did that, it was, just like in the adult rats, extremely neuroprotective. So if we dropped the temperature a little bit to 34 degrees, it was partially neuroprotective. And if we dropped it, the environmental temperature 31 degrees, it was virtually completely neuroprotective, and the animals didn't show any injury at all. And then if we looked post-ischemically, we wanted to look, just like in the adults, what it would look like if we cooled the baby rats after the asphyxial event. We found, again, very similar results that the adults did. If we did it for brief periods of time, it was in a moderate injury, which is in the yellow. So moderate means for us 90 minutes of hypoxia-ischemia. Severe is 3 hours of hypoxia-ischemia in the blue. And if we did that, we found that it was transiently neuroprotective, but not permanently neuroprotective. And in the severely injured rats, actually, it never provided neuroprotection. And then when we prolonged the extent to which we kept the babies cooled after the ischemic event, and in this case it was 12 or 24 hours, what we found was that in the moderately injured animals, it was permanently neuroprotective, as you can see here, after 24 hours of cooling, 12 and 24 hours of cooling. But in the severe groups, we actually never found any neuroprotection. And you'll recognize now that that's really not all that dissimilar from what people are finding clinically. And that work was replicated by lots of other labs, both in Europe and Australia and New Zealand and Canada and the United States. And so this is just a depiction that if you look here, they did some work in the pig. Maybe I'll use this. This will be a bit easier. In the piglet down at 4 degrees. In Thorsenson's group, they also did the piglet for 12 hours. In the rat, and mainly those two, actually, the piglets and the rats were the ones that were predominantly utilized. And there were variable degrees of neuroprotection across the board, depending on the duration of hypothermia that was used. And when people looked at delaying hypothermia, in other words, rather than doing it immediately after a hypoxia-ischemic event, waiting for periods of time, what we found was really a bit of a mixed picture. In other words, if the delay was for a couple or 3 hours, it seemed to be reasonably effective. But if you delayed the hypothermia for 6 hours or more, we started to lose that effect. And this is a study that was done by Alistair Gunn in New Zealand, right? Keep forgetting, sorry, where he's actually from. And so if you look here, there was early cooling 90 minutes after, and he did this in sheep, actually, and then he delayed the cooling for 5.5 hours. And he also delayed it after seizures. And if there were seizures involved, there was really no protection from the hypothermia in this particular experiment. And if he delayed the hypothermia for almost 6 hours, there was a variable effect with no improvement in the hippocampus, but some improvement in the superficial cortical regions and the parasagittal regions. And people looked at this in rats as well. This is Pabello in 2010. And they looked also, these are just a series of pictures from their studies. And they looked at delay of 2 hours and then a secondary delay of about 6 hours. And what they found is that the short delay, in other words, if you cooled the animals within 2 hours of the hypoxic ischemic event, there was improvement. And it was permanent in nature, lasting at least up to 6 weeks. But if you delayed beyond that and up to 6 hours, you lost that neuroprotective effect and it was no longer effective. And that's actually one of the reasons why it's not being used in neonatal stroke, because we don't really identify newborns who have stroke until they're 6, 12, or 36 hours of age. And so inducing hypothermia at that level based on these early studies will probably not be effective, although the specific experiments for that have not been done. And we then decided to try and figure out, well, we need to be a little bit careful about when you induce hypothermia, because as is often the case in most experimental procedures, people think, or everybody says, well, hypothermia is good, so let's just use it. And that's not always the case. So we actually decided to look at pre-ischemic hypothermia, because premature babies were being born, of course, and they would have intermittent bouts of apnea or bradycardia and intermittent bouts of ischemia. And of course, there's a whole group of babies who have congenital heart disease who also undergo ischemic events. And one has to be careful in how you apply certain experimental conditions to the clinical situation. You need to be somewhat precise. So we actually did both pre-ischemic hypothermia and pre-ischemic hyperthermia, in other words, increased temperature, to see whether or not and when that would be effective. And basically what we see here, and we did that in 3 different ways. We did 3 one-hour bouts in the 24 hours before. We did it a 3-hour bout 24 hours before, and then we did it immediately prior to the ischemic event. And you can see here that all these bars line up really nicely, which means that there actually was no protective effect of pre-ischemic hypothermia. But what was interesting, and this is one of the first studies that showed this, was that pre-ischemic hyperthermia actually was effective in protecting the brain. So presumably we induced some changes in the brain that would initiate protective mechanisms. And that's been followed up in a number of other studies to show that as well. So if we move on to mild hypothermia, and all the experiments that I talked about earlier, and excuse me, including quite a number of others done by predominantly Thorstenson and Gunn and others in Australia and the UK, moved trials on very rapidly to clinical trials, randomized clinical trials throughout a number of centers around the world, actually. And certainly one of the first ones was done by Peter Gluckman, and using the CoolCap trial. And what you can see here is he enrolled just over 200 patients in the control and cooling group. And similar to the next study that I'll show you, the findings were of interest, but you can see here, if you look just sort of under the p-value, which is the significance value, it wasn't as exciting as people would have probably liked to see, because if you go down this grouping here, really there is no statistical significance in any of the outcomes. So they wisely looked at EEG as well, and looked at some subgroupings, and then did find that there were some significant improvements in the cooling group compared to the non-cool group, particularly those who had undergone or who had had abnormal EEGs during their recovery phase. And so there was an improvement in their outcome at about 18 months of age if they had had an abnormal EEG compared to those who did not have an abnormal EEG, or sorry, who were not cooled and had an abnormal EEG. So that was the real big significant finding in the CoolCap study from its original presentation. Shankaran in the NIH group through the United States and some centers within Canada looked at roughly the same number of patients. Again, they looked at not cool cap but whole body cooling, which was a slightly different undertaking, and found really very similar results to the cool cap study. They did find some significant improvement with cooling for death or moderate or severe disability when they grouped those outcomes compared to those that were not cooled. And sorry, what have I got here? When we group these, when they sort of, I'm having trouble seeing here, I'm getting really old. When they grouped these even further, what they found was improvement in some of their outcome parameters compared to death. So since that time, there have been really quite a number of hypothermia trials, and George Simbruner has just completed the neuro trial as well. And all of them have used cooling for either 48 or 72 hours. The vast majority have reduced the temperature to roughly 33 to 34 degrees, and usually for about 3 days. And the vast majority have really found improved outcomes. Certainly the large trials, the Shankaran study, the Cool Cap study, and the Toby trial have all found relative improvements in those patients who were cooled compared to those who were maintained at normal thermic temperatures. And when we look, there's improvement in certainly death or severe disability, in survival, and in mortality. And now that we're seeing some improvement in those children who've had severe disability and cerebral palsy, as well as neuromotor and neurodevelopmental outcomes. So there certainly has been quite a marked improvement. Probably Georgia's study has shown the best outcome in terms of children who've had severe disability or severe HIE compared to the other two large trials. And that's a real important statement, because that's kind of the group who we were worried about is not getting any improvement from cooling. But in this trial, there certainly was, and largely doing, and George can obviously speak to this better than I can, but largely doing similar cooling methodologies as the other trials did, and also using whole body cooling as opposed to selective head cooling. So that's one of the best trials in terms of outcomes for our severe disability group. And again, a number of systematic reviews have been done actually by the Australian group and Susan Jacobs and Peter Davis, and I'm sure he can elaborate on these. But the important thing to find here is that all of these line up on the left of this straight line, which suggests that there is an improvement in outcome for those infants with both moderate encephalopathy, so a little bit better in the moderate group, and to some extent in those with severe disability, with Simbruner's probably showing the best results. The others kind of a bit marginal for the severe disability groups by comparison. And when individuals looked at selective head cooling versus whole body cooling, they also found, again, improvement for the total body cooling as well as the selective head cooling, but perhaps marginally better for the whole body cooling compared to the selective head cooling. So what are some of the side effects that people have recognized with the induction of hypothermia for about 48 to 72 hours? Well, generally speaking, I think we can all say that it's a relatively safe procedure, and that major adverse events have not really occurred. Bradycardia is probably the most significant one or the most common one. People have recognized some arrhythmias, some hypotension, some coagulation defects and thrombocytopenia, a bit of anemia, and some degree of hypoglycemia, all of which are either very easily correctable or, frankly, not clinically significant. And then people began to ask, well, is there a difference in outcome between the selective head cooling group and the whole body cooling group? In other words, is there a difference in what parts of the brain are improved, or what kinds of injuries are improved, and in overall outcomes? And this question has not been entirely answered, certainly not to my satisfaction, and I think probably not to most people's satisfaction. This is just a couple of photographs from a paper done by Terry Inder, and this is basal ganglia injury on the MRI that you can see there, and then cortical injury and basal ganglia injury that you can see here. And there was kind of anecdotally, people felt that if you were selectively head cooled, then you should have a sort of a hypotensive event and cortical injury, and if you were whole body cooled, you were better off having a basal ganglia injury. So depending on where you were, you'd have to fly to Australia or North America to get your cooling done, because each used a different thing. But really, I don't think that really has been completely answered. There's been some follow-up work done and subcategorization of the work that was done in some of the larger clinical trials. This is some work done by John Barks when they broke down some things and looked at MRI results, and you can see here in the pink that those individuals who were selectively head cooled compared to whole body cooling did slightly more poorly, I suppose, when it came to basal ganglia injury compared to the whole body cooling group. And using a scoring system that was derived by Barkowicz, they found the same thing. And if they looked at, Rutherford looked at predictability, MRI predictability in terms of outcome, and again found that if you look at the basal ganglia in terms of outcome, that can give you some degree of predictability in the cooled versus the non-cooled groups. In other words, the cooled group tended to shift to the left. They seemed to do better than the non-cool group when you looked at basal ganglia or the posterior limb of the internal capsule, but looking at the cortex was not very helpful in predicting overall outcome. So overall, I think if we sort of summarize some of that information, it looks as though whole body cooling may provide some improvement over selective head cooling, but I think that is not entirely well known at the present time. It's not, I think the answer is not completely there yet. So how can you predict if hypothermia excuse me, is going to be successful? Jeff Perlman does a lot of this work and breaks down studies really nicely, and has done that again with the Hypothermia trials. And he found that if you looked at some of the risk factors in the babies that were undergoing cooling, he found that you're more likely to be unsuccessful with hypothermia if your pH is probably less than 7, whereas those who were cooled and had an outcome, a normal outcome, had pHs of 7 and above. And if you obviously had a severe encephalopathy, and if you had seizures. So if a baby is going into cooling, or if a baby is a candidate for cooling, they have a very low pH, usually of less than 7. If they're a severe encephalopathic, depending on how you grade it, whether it's SARNAT or other means, or if there are seizures, then you're more likely to have a poor outcome, even if you're cooled, compared to those that don't have those parameters. Others, again, John Barks looked at this along with Sarkar, looked at looked at whether or not you had a sentinel event, so something like uterine rupture or abruption or a prolapse cord, to determine whether or not cooling would be successful. And really, not surprisingly, children or babies who had undergone a sentinel event were less likely to have a good outcome if they were cooled compared to those who didn't. So a sentinel event is what we refer to as a sudden, really complete interruption of blood flow, usually from the placenta to the baby, and will almost invariably result in basal ganglia injury. So some of the sort of take-home messages from the last few slides are, number one, if you have a severe encephalopathy, cooling probably not going to be as great. Two is if you have basal ganglia injury, which often goes along with a sentinel event, like a near-complete asphyxial event, cooling is not likely to do as good as you would if you didn't have those events. What is not entirely clear is whether or not cooling does any better than non-cooling in those. And at the present time, I think most individuals would lean towards the fact that it does do some benefit, and certainly outweighs any adverse events or adverse effects that it might have. So, and we can certainly discuss that after, but I would say that most people would still lean towards cooling as a standard of care, but there's lots of room for improvement in those babies who have severe encephalopathy. So just to quickly summarize, hypothermia is effective. I think there's not much question about that. It's more effective in the moderate group of HIE, but probably has some beneficial effects even in the severe group, and very few adverse events that are clinically important. And certainly it's becoming, I think, definitely a standard of care in most centers. Now, how many use hypothermia here as standard of care in their neonatal asphyxia babies? Is it everybody, or pretty much everybody? Are there centers that are not using it or unable to use it at the present time? Okay, and that's mainly economic reasons? Yeah. Interestingly, Michael Johnson, who some of you may know, I don't know if should be saying this or not, but anyway, he's developed through his group at Kennedy Institute a surprisingly cheap way to keep babies cooled, largely for developing countries like Africa and things like that, where they've developed actually a clay pot incubator, or a clay pot incubator. It's made out of clay, and their engineers have, because clay will maintain coolness, and they've developed a way of thermoregulating that, and they make these things for like $35, which is phenomenally cheap compared to most of the incubators we have. And so they're looking at ways, and through our network, we're looking at trying to get a grant to look at that in a randomized clinical trial in some of the developing countries. So this is really a methodology that is going to kind of go throughout the world. So why does hypothermia work? And I think many of us believe that hypothermia works probably because it has a very ubiquitous or a homogeneous effect on outcome and recovery. In other words, it doesn't target necessarily any one of these. It probably has a more holistic approach. In other words, dampening or inhibiting almost all of these cycle of events in some way or another. But when people have looked at what specific aspects, then we do find that it probably improves them all, but to various degrees. So we actually looked at seizures, and you'll remember that Perlman found that if you have seizures, then cooling probably won't be all that effective. But if you do something about the seizures, it might, and I'll speak a little bit more about that in my next talk in an hour. But we looked at inducing seizures in our rats. and cooling them. So what happens when you induce a seizure in a rat pup? It actually becomes hyperthermic. And that's true of humans as well. So if you just let a human seize away, they'll actually get warm. And if you do it in a rat, they actually also get warm. So the important aspect for us under those circumstances is if we maintain even just their normothermia, which would be relative hypothermia for a baby who's seizuring, or for a rat pup who's seizuring, will that improve outcome? And in fact, it actually does. So this line up here is the temperature of rat pups who are undergoing very prolonged seizures. This is their EEG, so it's actually seizuring away. And this is their a normal EEG when they're not seizuring. And then if we looked at the brain pathology, we can see here that using that cooling the animals prior to the onset of seizures, either right after the asphyxia or just before the seizure starts, actually improves their pathology pretty significantly. So cooling does reduce injury. It doesn't actually reduce the seizures as much as we thought it would, but it does reduce the amount of injury that we see. And why is that? Well, a number of people have looked at a host of different parameters, and this particular slide is just looking at the different inflammatory parameters and parameters of cell death. So this is looking at actually microglia cell death, and this is looking at apoptotic cell death. And if we look at cooling on the bottom here, we find that with ischemia you get a lot of injury, and if you cool the animals or the cells for 2 hours, or for 2 hours after, or for 6 hours, you get marked improvement both in the amount of inflammation and in the amount of apoptotic cell death as marked by caspase. We looked at whether or not there would be a preservation or an improved recovery of energy metabolism, and this is sort of the evolution of recovery. Generally speaking, you get a drop in energy and energy depletion, and then a secondary recovery, and then a secondary energy failure. And we didn't actually find any improvement in the overall energy recovery when we cooled the animals after hypothermia. But what we did find in our studies was that there was a marked improvement in the pro-inflammatory and the anti-inflammatory markers. So these are just indications of different inflammatory markers. This is IL-1B, which is a pro-inflammatory marker, and you can see that under normothermic circumstances it raises quite significantly, and under hypothermia or sham that effect is dampened quite a bit. The same is true almost identically for TNF-alpha, but if we look at IL-10, which is actually an anti-inflammatory marker, so they're both pro-inflammatory markers and anti-inflammatory markers in our system, hypothermia surprisingly increases the anti-inflammatory marker, which was a bit of a surprise to us because we felt it would sort of dampen that entire process of both pro and anti-inflammation, but in fact it dampens anti-inflammation and dampens pro-inflammation and enhances anti-inflammation, which is really, I think, quite a remarkable change. Myself and Rand Askelan in Toronto have looked at ways of determining whether or not we can enhance the outcome of hypothermia by looking at apoptosis and the core. And what we found is that under circumstances of hypothermia, the core shows a reduction in apoptosis compared to the penumbra, and believe it or not, these two slides are not statistically different. and that's using a Cas-based marker. When we've looked at apoptosis inhibiting factors, so part of the inflammatory, there's always a balance between pro-inflammatory and anti-inflammatory, pro-apoptotic and anti-inflammatory markers within our system because we're balanced systems. When we looked at hypothermia, the apoptotic inducing factors, so things that cause apoptosis or cell death, are dampened by hypothermia both in the core and in the penumbra. And when we've looked at X-linked apoptosis inhibiting factors, we found that they're enhanced. So again, what we're finding is that hypothermia actually, rather than causing just a systematic wide dampening of all these markers of inflammation and cell death, actually reduce the ones that are pro-cell death and pro-inflammation, and increase the ones that are anti-cell death and anti-inflammation. And that's an important finding from the perspective of trying to develop new ways of enhancing and complementing apoptosis. So moving on to what has happened in terms of outcome, this is some work done by the Sankran group and looking at their original series of from their clinical trial at 6 to 7 years of age, so newborns that are now 6 to 7 years of age. And you can see here that what they found is, again, death or IQs less than 70 are significantly improved by cooling. And when they separated them out, death for sure is an improved combination of death or disability. But really, they haven't been able to tease out the death component of things. In other words, they're still, I think, struggling to find some overall improvement within the aspects of disability, both motor and cognitive disability, and haven't been able to tease out the death component, which is not great. So people have now begun to look at neuroprotective therapies in association with hypothermia. We did some early work on our animals and looked at whether or not a host of different agents might improve hypothermia and severe encephalopathy. And we found that things like allopurinol and glutathione do have an additive effect on hypothermia in the severe groups. A number of groups, including particularly actually John Bark's group and Silverstein, have looked at a group of anticonvulsants, and this is some of their early work looking at phenobarbital in association with hypothermia, and found an improvement in their pathology score when combining hypothermia with phenobarbital compared to hypothermia alone. They've looked in terms of some behavioral aspects, and this is just a placing response of rats, and again have found that the pathology correlates well with the behavior, and have looked at a number of different areas of the brain, particularly the striatum and the thalamus, as well as regions of the hippocampus, and also found improvement. But when they looked clinically, when they did a retrospective study looking at a combination of phenobarbital and hypothermia in a group of children who had undergone both, they actually didn't find any improvement, which is kind of unfortunate, but not all that surprising. The same group looked at Topirimate, which is another anticonvulsant that's very typically used in babies. And again, they found a good effect, at least in rats, of the combination of Topirimate and hypothermia behaviorally and pathologically. And it's also a drug that's being recommended more and more for use in neonates as an anticonvulsant. Many of you will know that Thorsenson's group has been really pushing the Xenon, which is an anesthetic. And again, both in rats and I think in piglets, they found a really marked effect of the combination of Xenon inhalation with the use of hypothermia and in a graded fashion. So in other words, the more Xenon they've used in combination with hypothermia, or the greater the concentration, the greater the outcome, particularly in pathological scores that they've used, although they haven't really done much in terms of behavior. And another group, Singh's group and Dorothea Jensen, have looked at N-acetylcysteine and also found very similar results in rat models where they've looked at the use of N-acetylcysteine in combination with the Vannucci rat model, and found that there's an improvement in outcome for the combination of N-acetylcysteine and hypothermia compared to either one alone in a sort of a graded fashion. So you do get some improvement with N-acetylcysteine, you get some improvement with hypothermia, but you get a really additive effect when you combine the two. Enrique Agberger has looked at caspase inhibition, caspase-2 inhibition, and found very similar results pathologically when combining hypothermia with BAF, which is a caspase-2 inhibitor, in two studies now, one in early 2000 and one in 2012. So just the last couple of slides here. I think I put this in because these are recent studies by Donna Ferraro's group and a group in China that have looked at erythropoietin, and many of you know that erythropoietin has been used quite a bit in newborns for hematologic reasons. There's a big push, at least in the States, to use it in combination with hypothermia. And these are two early preclinical trials in animal models that have looked at a combination of erythropoietin and hypothermia, and actually neither one of them was effective. So this is actually the first drug in combination with hypothermia that hasn't been effective in preclinical trials, even though it's the one, at least in North America, that is being, I think, pushed most aggressively. I don't know about the UK, and maybe you can speak to that, which is unfortunate. Both pathologically and in terms of behavior, the combination of the two has not been effective. And I know that, at least from a funding perspective, that is not moving forward. There's also been some work done from a quality of life perspective, and parents, interviews or focus groups with parents whose children or whose newborns have undergone hypothermia. And they too sort of have recognized or indicated that a real sensation of what they refer to as experiencing almost a moment of rebirth when their children undergo hypothermia and presumably do better. So it has a real emotional component to it as well. So hypothermia is clearly something that, in my opinion, is obviously here to stay. It's probably going to spread like wildfire in the next 5 to 10 years, hopefully into the developing countries where perinatal asphyxia is actually way more prominent than it is in North America or Europe. We're going to be looking at, I think, a combination of therapy if that's in preclinical trials going to prove to be effective. I think more and more we'll look at delayed hypothermia and perhaps even more prolonged hypothermia. We'll start to look at other possibilities. Is it effective in neonatal stroke at either greater depths of hypothermia or for more prolonged periods of time? Is it affected in other forms of neonatal injury, whether it's hypoglycemia or sepsis or NEC? And there's some early studies to suggest that it is. And what about the premature infant, who obviously encompasses most of our nurseries anyway, and is it going to be effective under those circumstances? And I think we have to be careful about translating the work done in term babies to premature babies, because they're not the same. There's the same difference as adults to prematures. So, and that certainly is moving. People are going to look at whether there's going to be some movement towards the preterm infant. People are going to look at whole body versus selective head cooling a little bit more carefully. And then finally, we'll just end with some conclusions. So it definitely has a role to play. Brief hypothermia, so just for a short period of time, really doesn't seem to have a permanent neuroprotective effect. So I think we're looking at days of hypothermia as opposed to hours of hypothermia. Prolonged hypothermia may provide better protection, especially in those with severe encephalopathy. It's safe. We need to look at additional things, and we need, as I said, to look at whether or not what's the best methodology to use for hypothermia, and perhaps different injuries will actually be improved by different methods. In other words, it's possible that basal ganglia injury will do better with whole body, but cortical injuries will do better with specific head cooling, and those are probably important questions to ask ourselves and hopefully answer. So I'll end with that slide, and certainly happy to take any questions. Thank you. Any questions? Yes.
Talking about adverse effects, I've been to a seminar talking about the pharmacology of metabolism during hypothermia, and they said that you have high levels of benzodiazepines during the hypothermia treatment, and that you could also see high levels of morphine. So they advise not to treat with high levels. And I think in Gothenburg they changed treating the children with aminoglycosides during hypothermia and changed it to cephalosporins, not to have high levels.
Yeah. I think that's probably a general rule of thumb, that metabolism of whatever medications you're using is going to be slowed down. Certainly in our animal models, and I think in some of the human trials, even things like glucose concentrations glucose is not used as rapidly as under normal thermic circumstances. So those are things we're going to have to get a better understanding of, particularly as it relates to some of the other systematic or physiologic effects that hypothermia does. Because this is really meant a paradigm shift, in my opinion, for how we look at newborn infants. If this is a standard of care in most nurseries, then everything we've learned up to this point under normal thermic circumstances really changes a bit. And we have to sort of relearn what MRIs mean when they're done, either during hypothermia or after, what drug levels we need to use under those circumstances if we're going to use drugs, how to control things like blood pressure and glucose concentrations. I don't think those will be hard. I mean, I'm not the one that does them, these guys do, but I don't think it'll be too hard. But we do probably have to recognize that there's a new norm under those circumstances as opposed to what we've looked at before. And that's important.
Thank you very much, Sharon, for this wonderful overview. There's one thing we are observing a little bit in Germany with the wider and wider spreading of hypothermia. Some people kind of forget that these infants are generally quite sick. And in an asphyxiated baby, the event of the development of pulmonary hypertension is very likely. So if in your center you're planning to introduce hypothermia, you should be sure about having nitric oxide available or even ECMO in an infant that is severely asphyxiated, because eventually you run into other problems.
Yeah, that's a good point, obviously. We've been using nitric oxide intermittently, obviously in the kids who do develop signs of pulmonary hypertension. I don't believe we've gone to the point of needing or requiring ECMO, which is, yeah. No, absolutely. Yeah. you know, I think that goes to how one looks at introducing hypothermia into sort of a standard of care. Is it's not just introducing hypothermia, it's recognizing that there may be other things that come along with that as adverse events that will require some attention. Yes?
Could you tell me, please, how does hypothermia affect gas exchanges in term babies, in an asphyxiated term baby who needs maybe ventilator support?
So I'm going to defer that to the neonatologist because I don't know the answer to that. Does anybody want to? Yeah, I think we're going to have a little question and answer period at the end of the morning briefly. So remind us to answer that. If not, thank you very much.